We often think about age as, just a number, a date on a calendar.
Right. Simple.
But what if that simple number just isn't enough, especially when we're talking about something as critical as cancer care?
Yeah.
Today, we're doing a deep dive into a really quite extraordinary set of guidelines that are reshaping how we approach oncology for older adults. It's about moving way beyond just the year you were born. Our mission here is to pull out the most important, the most practical insights from some key medical sources, specifically the latest NCCN guidelines for older adult oncology, so that you can be really well informed on this.
And what's really foundational here, the big idea, is this shift.
Yeah.
Moving away from defining an older adult just by their chronological age.
Okay.
And focusing instead on their physiologic age and their function.
Yeah.
How they actually are.
Physiologic age, so function.
Exactly. And this difference, it isn't just, semantics. It's absolutely vital for personalizing cancer treatment. It acknowledges the huge variability in how people age, how they handle illness, how they might respond to therapy.
So, we've all heard that phrase, age is just a number.
Sure.
But here, it sounds like it's actually a clinical reality. It's not just a nice saying.
Precisely.
When these guidelines say there's no chronologic age thresholds to define an older adult, what does that really mean for, say, how your care plan might be put together?
It means we can't just automatically say, okay, you're 65, so treatment X isn't for you, or you get treatment Y.
Right. Like the Medicare age, for example.
Exactly. While 65 is often linked to benefits like Medicare, these guidelines make it super clear that your birth year alone. It's just not a reliable way to gauge your actual health or your functional reserve, your ability to bounce back, or even your risk of complications from treatment. The reality is people age so differently.
Yeah.
You could have an 80-year-old who's incredibly fit and active,
Yeah, I know people like that.
and maybe a 60-year-old who's dealing with a lot more health issues, much more frail. And this is especially important because historically, older patients, they've often been underrepresented in clinical trials.
Right, I've heard that.
And that lack of representation means we actually have less specific, evidence-based data for their care, which makes this personalized, function-based approach even more critical now.
So it comes down to your individual capacity, your situation, not just the date on your driver's license.
That's it.
Okay, so if that's the starting point, how do these guidelines make sure that the treatment plan, your plan, really lines up with what you need, what you value, what your goals are?
Yeah, that's absolutely central. Before any cancer treatment starts, the guidelines really stress assessing your values and your goals about the diagnosis. It's not just a tick box exercise.
Okay.
It's about making sure the plan truly reflects what matters most to you. And that includes looking at your decision-making capacity.
Right. Can you understand the information, weigh the options?
Exactly. Do you get it? Do you appreciate your situation? Can you reason through it and communicate your choice? And if, for whatever reason, that capacity isn't there, then it's critical to get information from proxies, from advanced directives, living wills, healthcare power of attorney documents.
So those documents become really important.
Hugely. And the guidelines say they should be proactively sought out for all patients when treatment starts. It's about ensuring your preferences lead the way no matter what happens.
That really does sound like a true partnership in care.
It aims to be.
But thinking about the healthcare providers, how do they get that kind of holistic view? How do they see beyond a standard medical exam to understand someone's real capacity and needs? Is there like a specific tool they use?
Absolutely. And this is where something called the Geriatric Assessment, or GA, comes in. It's really seen as the cornerstone of care for older adults with cancer.
The GA, okay.
Yeah. It's a multidisciplinary, pretty in-depth evaluation. It looks comprehensively at the objective health of an older adult across several key areas or domains.
Multidisciplinary. So not just one doctor.
Ideally, no. It brings different perspectives together, and its purpose is really to help predict your overall prognosis, guide treatment choices, and estimate how well you might tolerate that treatment.
And what are the benefits of doing this GA?
Oh, they're significant. It can uncover reversible geriatric problems, things like maybe malnutrition or undiagnosed depression that routine oncology care might just miss entirely.
Wow, okay. Reversible problem.
Yes. It can also help predict your risk of treatment side effects, toxicity. It aids in estimating life expectancy, which is important for some decisions. And ultimately, it can improve your quality of life and even help you stick to your therapy plan better.
That sounds incredibly valuable. How long does something like this take? Is it practical?
That's a fair question. A full GA might take around 20 minutes, maybe a bit more. But importantly, many of the individual tools within the GA, they can often be completed in under 5 minutes. So it's designed to be integrated into care.
Okay, that makes sense. So, for you listening, the key thing here is that the GA isn't just another test. It sounds like it's a really personalized map
That's a good way to put it.
that can uncover hidden strengths or maybe vulnerabilities, guiding a safer, more effective treatment journey that's really tailored for you.
Exactly.
So let's unpack these domains then. What specific areas of your health and life does a GA actually cover?
Okay, let's break it down. First, there's function and mobility. Basically how you move through life.
Right, day-to-day stuff.
Precisely. The GA looks at self-reported instrumental activities of daily living IADLs. These are the more complex tasks, like managing your money, using the phone, taking medications correctly.
Okay.
And also activities of daily living ADLs, which are more basic self-care, like bathing, dressing, eating.
And why is assessing this so important for cancer care?
Because needing help with those IADLs, those complex tasks, it's directly linked to things like decreased tolerance for treatment and, unfortunately, poorer survival.
Wow.
There are objective measures, too, like the timed up and go test, the TUG test, basically how quickly you can stand up, walk a short distance, turn, walk back, and sit down.
I think I've seen that one.
Yeah, it's common. A score of 13 seconds or more suggests an increased risk of falls, and even something as simple as gait speed, how fast you walk. A faster gait is actually linked to a lower risk of death.
Interesting. So what happens if issues are found here?
Well, interventions can be put in place, referrals to physical therapy, occupational therapy, maybe a home safety evaluation to reduce fall risks, practical stuff.
Okay, that makes sense. What's the next domain?
Next up is comorbidities and medications. And this often gets called polypharmacy.
Right, having multiple health conditions and taking multiple medicines.
Exactly. The GA recognizes that older adults often have other health issues going on, heart disease, diabetes, kidney problems, you name it. And these can really impact cancer treatment choices and outcomes.
Yeah.
And there's a really crucial point here, especially for clinicians listening. Serum creatinine, that common blood test for kidney function. It's not a reliable indicator in older adults. Muscle mass decreases with age, which affects creatinine levels.
Oh, interesting. So what should be used instead?
Calculation of creatinine clearance is recommended. That gives a much better picture of kidney function for adjusting doses of drugs that are cleared by the kidneys.
Got it. Creatinine clearance.
And then there's polypharmacy, taking multiple medications. This includes potentially inappropriate ones. There are tools used here, like the Beers criteria.
I've heard of that.
Yeah, it flags medications where the risks might outweigh the benefits in older adults, maybe certain sedatives that increase fall risk, for instance, and also the Stop PP Start criteria.
Okay, what are those?
They help identify potential prescribing omissions, like, are you missing a medication you should be on? Or duplications, are you getting 2 drugs for the same thing unnecessarily? And regular medication reconciliation is vital, checking everything prescriptions, over-the-counters, supplements.
Vincent's too.
Absolutely. Checking for interactions, and also addressing potential issues like opioid use or other substance misuse. It's a thorough review.
Really covering all the bases there. Okay, what else does the GA look at?
We also need to assess cognition and psychological health. This is about thinking, memory, and mood.
Right, which seems critical for understanding treatment and making decisions.
Exactly. Assessing cognitive function is vital, especially if it might affect planning treatment, actually delivering it, or your capacity to make decisions. The GA helps differentiate between, say, mild cognitive impairment, dementia, which is a progressive condition affecting daily functions, and delirium. And this is important. Delirium is often an acute onset, a sudden change, often fluctuating, and it's frequently preventable.
Preventable, that's key.
Very key. There are common screening tools you might hear, names like Minicog, MMSE, MoCA, CellMS for cognition. And for psychological health, things like the Geriatric Depression Scale, GDS, the Patient Health Questionnaire, PHQ, or the Distress Thermometer.
Lots of tools available.
Yes. And for delirium prevention, the guidelines strongly recommend non-pharmacologic interventions first. Things like keeping the patient oriented, mobile, hydrated, addressing sensory impairments.
Makes sense. Okay, what's the final domain?
The final piece is nutrition and social support. The broader picture.
Nutrition seems obviously important.
Hugely. Malnutrition is really common in older adults with cancer, often underdiagnosed, and it's serious. It's strongly linked to increased mortality and more chemotherapy side effects.
How is it assessed? Are there specific signs?
Yeah, practical indicators include unintentional weight loss, like losing more than 5% of body weight over 6 months, or maybe 5% in just 1 month, or 10% in 6 months, or a low body mass index, a BMI of 22 or less.
Okay.
There's a validated tool called the Mini Nutritional Assessment, or MNA, that's often used, and this ties directly into social support.
How so?
Well, a lack of social ties, feeling isolated, that's a significant predictor of mortality, independent of other factors.
Wow.
Really? So the GA uses tools to assess this, like the MOS Social Support Survey or the UCLA 3-item loneliness scale. And it's crucial to assess the caregiver situation too. Who's helping out? What support do they have?
That's a really comprehensive picture. It's amazing how many different factors play into this, isn't it? Really shows how complex aging is.
It absolutely does. It's not one single thing.
So, okay, armed with this incredibly detailed picture of you from the GA, how do these guidelines then actually inform the use of specific cancer treatments? Does age, after all this assessment, still end up limiting your options?
No, not inherently. And that's the core principle, hammered home again and again. Advanced age alone should not be the only reason to deny someone potentially effective treatment.
Okay, that's clear.
The guidelines push hard for multidisciplinary care teams getting different experts involved and really patient-specific approaches. And importantly, they also state that observation or watchful waiting can be a perfectly appropriate approach too, if it aligns with your preferences and goals.
Right. Not every cancer needs aggressive treatment immediately.
Exactly. There's a helpful framework mentioned, the 4 M's from the Age-Friendly Health Systems Initiative.
The 4 M's.
Yeah. What matters? Making sure care aligns with your goals and values. Mobility, keeping you moving safely, maintaining function. Medication, ensuring treatments are necessary, not redundant, and minimizing side effects. And mentation, preventing, identifying, and managing any cognitive issues like delirium or depression.
What matters? Mobility, medication, mentation. Okay, that's a neat summary. So how does this apply to specific treatments, like surgery?
Well, for surgery, again, your chronological age isn't the main driver of risk. Instead, it's that comprehensive assessment of frailty components. We talked about your comorbidities, cognition, mobility, functional status, nutrition.
So the GA findings directly inform surgical decisions.
Yes. And there are tools, like the ACS NSQIP Surgical Risk Calculator, that can help estimate patient-specific risks and benefits, which is great for shared decision-making conversations.
Good to know. Are there specific complications to watch for after surgery in older adults?
The big one is postoperative delirium. It's the most common complication. But again, the good news is it's often preventable with proactive strategies.
Okay. What about radiation?
For radiation therapy, or RT, the message is similar. It can be highly effective and generally well-tolerated in older adults. Age alone shouldn't limit its use.
Are there newer techniques that help?
Absolutely. Modern RT techniques like IMRT, intensity-modulated radiation therapy, and SABR stereotactic ablative radiotherapy are much better at targeting the tumor while sparing nearby healthy tissues. This improves what we call the therapeutic ratio.
Better targeting, fewer side effects, basically.
That's the goal. But there is a note of caution about using radiation concurrently with chemotherapy. That combination can sometimes lead to increased toxicities, so it needs careful consideration.
Right. Okay, and what about chemotherapy itself?
The guidelines state that well-selected older patients, particularly those with good performance status, meaning they're fairly active and functional, can often tolerate chemotherapy just as well as younger patients.
So selection is key.
Selection, based on that comprehensive assessment, yes. And here's a really key insight from research studies like GAIN and GAP70+. Using the Geriatric Assessment to guide care has been shown to significantly reduce chemotherapy-related toxicities.
Wow, that's huge. So the GA actually leads to safer chemo.
That's what the evidence suggests. There are also specific chemotherapy toxicity risk calculators, like the TR Chemotoxicity Calculator or the TR-ASH score. These tools use information from the GA and other factors to estimate your individual risk of serious side effects, which can help guide decisions about chemo doses, maybe starting lower or using supportive measures.
Very practical tools. Now, what about the newer treatments we hear about, targeted therapies, immunotherapies, CRRT cells?
Right, emerging therapies. So for targeted therapies, older patients seem to get similar clinical benefits as younger patients. However, the side effect profiles might be less well understood in this population, so they often require closer supervision.
Okay. And immunotherapy, immune checkpoint inhibitors.
With immunotherapy, again, similar clinical benefits are generally reported,
Yeah.
but there are some concerns about potentially increased or sometimes different types of toxicities in older adults. So closer monitoring, maybe more aggressive management of side effects is often needed.
Okay. Different toxicity patterns?
Possibly. And for CAR T-cell therapy, which is a type of cellular therapy, response rates look similar regardless of age. But older adults, especially those identified as frail by the GA, might have a higher risk of neurologic toxicities, issues like confusion or movement problems. So very close monitoring is essential there.
It sounds like across the board, while age isn't a barrier, careful assessment and monitoring are absolutely critical.
That's the takeaway, yes.
Huh.
Personalized vigilance.
Given that older adults might have, as you said, less reserve to cope with side effects, what are some of the most common complications seen, and how do the guidelines suggest managing them?
Yeah, it's true that complications can hit harder, they can be more clinically significant, and they definitely require more intense surveillance. And as we touched on, polypharmacy and even non-prescribed things like supplements can unfortunately amplify these side effects.
Right. So what specific toxicities are common?
Okay, some specific toxicities to highlight. Cardiac toxicity is a concern with certain drugs like anthracyclines or trastuzumab, requiring careful heart monitoring. Renal toxicity, we mentioned the importance of calculating creatinine clearance for dose adjustments. Neurotoxicity, needing to monitor for issues affecting balance, coordination, cerebellar function, hearing loss, and especially peripheral neuropathy, which is nerve damage in hands and feet, as that increases fall risk.
So again, okay.
Always a concern. Myelosuppression, meaning lower blood counts. Older adults have a higher risk of neutropenia, low white cells, anemia, low red cells, and thrombocytopenia, low platelets. This might require using growth factors to boost counts or specific management for anemia, though caution is advised with certain agents called ESAs and careful monitoring for bleeding risk with low platelets.
Okay. And GI issues?
Yes, GI-related side effects like nausea, vomiting, diarrhea, and mucositis, mouth sores, need proactive management, with a big emphasis on nutritional support to prevent weight loss and dehydration.
So those are treatment-specific side effects. What about just general issues common in older adults that might be worsened by cancer or treatment?
Good question. The guidelines address several common older adult issues. For insomnia, non-drug approaches are first-line things like improving sleep habits
Sleep hygiene.
or cognitive behavioral therapy for insomnia, CBTI. They specifically caution against using benzodiazepines or common over-the-counter sleep aids with antihistamines as a first step, due to risks like confusion or falls.
Right. Avoid those if possible.
Definitely try other things first. For falls, as we've mentioned, periodic assessment is key, asking about history of falls, checking balance and gait. Early use of things like walkers or canes, durable medical equipment, and home safety evaluations are recommended. And reviewing medications to see if any might be increasing fall risk is crucial.
Makes sense. Anything else?
Yes, infection and immunosuppression. Cancer treatment can weaken the immune system, so ensuring patients are up to date on all recommended vaccinations, flu shot, pneumonia vaccine, shingles, COVID-19 is really important.
That's a lot to manage, but it sounds like a very proactive approach to potential problems.
It has to be. Anticipating and managing proactively is key.
These guidelines seem incredibly thorough, looking beyond just the active treatment phase to, longer-term well-being. How do they advise on things like cancer screening or surveillance for older adults? Is it different?
It is different, and this is a really important point. Routine cancer screening, looking for new primary cancers, and surveillance testing, looking for recurrence of a prior cancer, aren't universally recommended for all older adults. The decision really hinges on life expectancy.
Life expectancy, how does that factor in?
Well, the guidelines suggest that for cancer screening for new cancers, if someone's estimated life expectancy is less than 10 years, the potential benefits of screening are unlikely to outweigh the harms.
Harms like?
Things like the discomfort or risk of the screening test itself, anxiety, false positives leading to more tests, and potentially overdiagnosis, finding a slow-growing cancer that might never have caused problems in the person's remaining lifespan, but leads to treatment with side effects.
Okay, that makes sense. Avoid overdiagnosis. What about surveillance for recurrence?
For surveillance testing for recurrence of a previous cancer, the threshold is generally considered a life expectancy of less than 5 years. Again, if the remaining lifespan is relatively short, intensive testing for recurrence might not change outcomes or improve quality of life. and could just add burden.
So it's about balancing potential benefit against potential harm and burden.
Exactly. And crucially, these are not hard and fast rules, but guidelines to facilitate shared decision-making between the doctor and the patient, considering their individual situation and preferences.
Right. Always coming back to the individual. Now, what about the people supporting the patient through all this? The caregivers. They seem absolutely vital.
Oh, incredibly vital. Caregivers are often the unsung heroes, aren't they? They provide so much practical help, physical care, medical tasks, social support, financial assistance, and advocating for the patient.
It's a huge role.
It is. And the guidelines specifically point out that caregivers themselves experience substantial stress, emotional, physical, psychological. It takes a toll.
So do the guidelines recommend assessing the caregiver too?
Yes, absolutely. It emphasizes the importance of assessing their needs and their level of burden. There are rules for this, like the Zarit burden interview. It's about recognizing that the caregiver's well-being impacts the patient's care too.
What kind of support strategies are suggested for caregivers?
Several things. Providing them with tailored education about the patient's condition and treatment, actively involving them with the patient's permission, of course, in treatment decisions and advanced care planning discussions. Encouraging them to seek community and professional support, like connecting with social workers or using respite care services to get a break.
Respite care, yeah.
And utilizing things like telehealth can sometimes reduce the burden on caregivers, making appointments easier to manage. It's about supporting the whole support system.
That feels really important, acknowledging the caregiver's burden. It seems like communication underlies everything we've discussed. How do these guidelines help ensure that communication is effective, especially when things are so complex and the stakes are so high?
You're right, communication is critical. Optimizing it is essential for good outcomes. The guidelines start by stressing the need to assess for any barriers to communication first.
Like hearing loss or vision problems.
Exactly, sensory impairments, or maybe cognitive impairment that affects understanding. Once barriers are identified, specific strategies are recommended.
Such as?
Things like avoiding medical jargon. Simple language is best. Instead of benign, say not cancer. Instead of metastasized, say the cancer has spread.
Okay, clear and direct.
Offering written instructions is also key, and they even give specifics. Aim for about a 5th grade reading level. Use 14-point font or larger. Black text on white paper is easiest to read, and include pictures where helpful.
Very practical tips. What about spoken communication?
Techniques include facing the patient directly, speaking slowly and distinctly, pausing between topics to allow processing, and this is really important, using the teach-back method.
Teach-back? What's that?
It's where you ask the patient to explain back, in their own words, what you just told them or what the plan is. It's not a test of their memory, but a check of how well you explained it.
Yeah.
It confirms understanding.
Ah, I see. That makes sense. Check your own explanation.
Precisely. The guidelines also specifically recommend avoiding elder speak.
Elder speak.
Yeah, it's that kind of patronizing, overly familiar, sometimes high-pitched way of talking to older adults, almost like baby talk, using terms like dearie or sweetie or overly simple sentences. It could be perceived as disrespectful and actually hinder communication.
Right. Treat adults like adults.
Fundamentally. And finally, they do mention the benefits of digital communication and telehealth. These can be helpful for older adults, sometimes providing a window into their home environment and making it easier to include family members or caregivers who might live far away.
Wow. This deep dive has really revealed, I think, a truly patient-centric way of thinking about older adult oncology. It's clearly not about just pinning everything on an arbitrary number, a birth year. It's about seeing the whole you.
Exactly. Your physiology, your function, what you value, the support system around you, and your unique ability to navigate treatment.
It feels like a much more respectful and effective approach.
It aims to be. And maybe, just to leave you with something to think about, this paradigm shift, moving from just chronological age to this holistic, geriatric assessment-driven approach.
Yeah.
Well, it isn't just about cancer, is it? What broader implications might this evolving understanding of age, focusing on function, on individual capacity, have for how we approach health, medicine, and even just aging in society across all disciplines? Something to mull over.